Good morning, welcome everyone. Thank you so much for joining us for this installment of SIR's Global PAD Bootcamp webinar. My name is Shalo Adanakinju and I'm an IR Fellow at Mount Sinai, New York, and I'm currently part of the SIR RFS Vascular Service Line. Although I've had different hats in the organization, PAD is a special place in my heart, and so my excitement for this morning is really through the roof. SIR RFS, in collaboration with the Interventional Radiology, with the Society of Interventional Radiology, the Indian Society of Vascular Interventional Radiology, and the British Society of Interventional Radiology, is very excited to continue this series of webinars on peripheral arterial disease, one of the most prevalent diseases worldwide. With this global endeavor, we hope that we can spark your interest in the world of PAD and ultimately equip you with the knowledge needed to help patients in your community. We have some of the most experienced and enthusiastic international faculty taking charge to lead us through this webinar. With us, we have Drs. Kumar Mandassari and Dr. Keith Pereira, who will be our moderators today. Today's lectures will be given by Dr. Bjorn Arslan, Dr. Agnes Solberg, Dr. Jos Vandenberg, Dr. Rojan Pont, Dr. Maria Anotella Rufiano, and last but not least, Dr. Srini Tumala. With that being said, let's just go over some housekeeping before we get started. We'll be following this fantastic agenda today, and your active participation is our priority throughout the session. Right now, everyone is on mute to avoid background noises. You can enter your questions in the comments, questions and comments in the question box throughout the bootcamp, and they'll be answered by the faculty. Please do not ask questions in the chat box. A recorded version of this webinar will be available at a later date on the SIR RFS IR Education YouTube channel. Now, without further ado, let's turn our time over to our wonderful moderators, Dr. Mandassari and Dr. Pereira, to kickstart this bootcamp. Let's make Charles' daughters proud.
All right.
Thank you so much. Go ahead.
So, Dr. Mandassari and Dr. Pereira, you can take over now, and I've made Dr. Arslan as the presenter because he's the first person to present.
Fantastic. Thank you so much for that great introduction, and thank you to Rakesh and everybody from SIR RFS and SIR as well for helping us facilitate this kind of ongoing webinar series so that we can really inspire, spearhead, network, and help our fellow interventional radiologists around the world that are trying to learn and improve on their PAD practice. And a big thanks to all of our speakers today from multiple countries, and none of this would happen without all the efforts and you dedicating your time to doing this. So myself and Keith, we're very fortunate to have all of you guys willing to take your Saturdays to do this with us. Thank you so much. I guess we'll start off because we're going to try and march down from the aorta to the toes, distal aorta to the toes, with somewhat of how do you take on complex cases, not too detailed, but how do you approach this? And none better for aortoiliac than someone who taught me quite a bit and is still teaching me quite a bit, Dr. Bjorn Arslan from Rush. So if you want to take it over, Dr. Arslan, we thank you so much.
Thank you very much, Kumar. This is great. I mean, having this with our trainees and upcoming IRs is a wonderful thing. And aortoiliac is somewhat of my passion, so I'll try to show a couple of cases, interesting cases, and at the same time we'll go over some kind of techniques and approaches how to treat these problems. So in the aortoiliac disease, you know, the things that defines your success is, number one, crossing the lesion in a safe manner and ability to treat the occlusive segment with the right tools and long-term patency. This is just in a nutshell. And that's your goal, right? If you can't cross it, you can't treat it. If you don't use the right tools, your treatment is not going to be long-term or successful. So there are a lot of devices out there which you're going to be familiar over the course of your trainings. And there's going to be probably more of them coming up. So I'm just listing a couple here, but the important point is as you go into your career, to learn these devices, whatever is available, and be familiar with them, and then use the ones that help you, that you're comfortable with, and then you just kind of, those become your go-to tools. And in the meantime, at certain times, you can still kind of try new things, this and that. The goal is for you to achieve the success. And I'm just going to add something. In our, I think Kumar can kind of quote me here, our success in aortoiliac occlusive disease is 100%. The only ones that we sometimes do hybrid with our surgical colleagues, if the disease is completely involving the femoral arteries, etc., then in combination with femoral arterectomy, etc., we do some of those procedures. But if there's a femoral segment that's patent, there's nothing you can't cross and treat pretty much. And so the cheap tools that we need, the most common one that you'll need is a Bernstein catheter and a glide wire. If you're going up and over, you may need the SOS catheter, which is also a very cheap tool. We have used the 1/8 glide wire backhands for crossing certain kind of difficult areas, or you can use heavy tip, which is a lot more expensive, crossing wires 014 or 1/8 in certain scenarios, and pretty much anything else. These are things that we commonly use, but that doesn't mean that you're going to end up using these. In terms of treatment, we used to use stents, especially balloon expandable in the iliac segment, self-expandable in the external iliac segment. In the iliac segment, you need to be precise, and they're relatively larger arteries compared to external iliac. External iliac are more tortuous in general, so self-expanding stents in general are okay, but there are exceptions to both rules in certain cases. You have to take it case on case. Stent grafts have become a lot more common. My go-to is for long-term occlusions. I use a covered stent graft, balloon expandable in the iliac, common iliac segment, and then in the external iliac segments, use a self-expandable wire bond in general. And you can combine these two at certain levels, and depending on if internal iliac is an option, is a problem or not, you may have to be even more creative on select cases. And then the other importance of stent graft is when you're dealing with very chronic calcific occlusions, there is the risk of rupture. And the common iliac is relatively rare, but it can still happen if you're too aggressive. And the external iliac is a little bit more important that you need to be aware of. You're ballooning a calcific external iliac. If you don't have a stent graft ready, if a rupture happens, it would be a problem. I guess you can leave your balloon up and then try to salvage the scenario that way, but then you're calling the vascular surgeon instead of fixing it by yourself. So keep that in mind. And how do I do it? I usually get a CTA or MRI. So knowing the anatomy is very important, unless you already have an angiogram, etc. And if femoral arteries are patent, you can obtain. I usually start from the femorals, and bilateral access is very common. I keep my threshold very low. If you have a one-sided occlusion iliac and then you have a stump, you can try to do it from, one access retrograde, and if you cross it in a nice manner without being in the subintimal, and you're entering the stump in a nice way, so you can treat everything from one access, but that's usually not the case. So be ready to get the second access, and by flushing, going up and over, it also helps you for stent deployment. Your second access you can use as a diagnostic tool just when you're deploying your stent, so you're more precise. And use the angle catheter from the lateral access with a Bernstein. And if you're coming from the other side, you can use the SAS and kind of advance, or a Simmons, etc., reverse shaped catheter to go downward into the occlusion. And nowadays we have steerable sheaths that are very helpful, but they're also much more expensive. So that's another tool that you can use in complex cases. If your regular 5 French catheters, etc., are not working, you can go to these expensive tools, a lot more stability and options. So again, in my experience, the cheap method will take care of 80% of your cases, and then in the rest, you can start using the re-entry devices, steerable sheaths, this and that, and then spend a lot more, but still be able to be successful, achieving 100% success rate. In the shorter lesions, anything will work. Long calcific lesions, again, we talked about the stent grafts are probably better for patency purposes. I'm going to start with a case. This is my first case that I did by myself about a year out of fellowship. 62-year-old male, cardiomyopathy, can't get anesthesia, smoker, ABIs are 0.2 and 0.3. You know, it's a very, also COPD, very terrible patient. This is our angiogram from one side, and then this is the other angiogram right on the left side, as you can see. Total occlusion of the aortoiliac segment. So the final angiogram was done from above. You can see here is patent by tapering down to the level of iliac. It extends into the common iliac on one side, but total occlusion of the common and external on the other side. And then it continues as an internal iliac, so it doesn't even have a kind of a stump for the external iliac on the side, on the left side. So in this case, we started from above, as we kind of initially couldn't cross from below. This is the rest of the angiogram. I'm just going to go through. After crossing through from above, it was good. We ballooned and then ended up stenting it. At that time, we did not have the right covered stents, so we used self-expanding stents and ballooned it. And then we did the same thing from above. We were able to cross it without using additional tools. But since I'm coming from the arm, I put the stent on the other side, so I have this chunk of calcium. This is a great case to demonstrate how the kissing ballooning works. That kind of steered over to the other side, which was initially treated. So I kind of balloon one side, you know, pull my wire back, and that plaque keeps moving one or the other side without giving me kind of a good outflow. And but again, now we recanalize. So keep your threshold low, put your wire from brachial to one side, and access the other side, and then get a second wire. That way, again, this is one more try which didn't work. And finally, we got wires from both sides and did a kissing balloon and extended the stents a little bit, and we got rid of the problem. We got excellent flow. And this is the rest of his angiogram. This is another patient, 74-year-old, presenting with bilateral rest pain and severe claudication, can't walk a block, and then waking up at nighttime from the pain. And this is his angiogram. The right side was the problem in this patient. As you can see, there's severe common iliac, external iliac, and internal iliac disease. Internal iliac is stenosed, but the external iliac is totally occluded. The left side isn't that bad. This patient does have a relatively kind of sharp angulated arch. And again, we tried from the ipsilateral side. We got stuck in the external iliac artery, subintimal space. Then we come from above from the other side. And now we have wire and catheter from the other side. This is a SAS catheter and a glide wire. And this is from the below. We have like a small sheath at this point. You usually have to use 6-7 French sheaths for these interventions for eventually treat things. And now we have, to get us better support, we have a steerable sheath from the left side, give us a little better support. From this steerable sheath, we end up putting a snare into the area that we wanted to enter the artery. And from the right groin access, we used an outback catheter to target that snare because they're on different lumens and we can't meet them. And every time we push our wire, we get stuck in the subintimal lumen in the common iliac. So using the outback catheter, we were able to enter the snare. And after we did that, we had, you know, bilateral access and then through and through access, flushing the patient from right groin to left groin. But at this point, you can see that internal iliac is also very diseased. And that has been his lifeline. So you don't want to sacrifice that in this case. So we accessed that internal iliac and then stented that internal iliac. And then we also stented the external iliac into the common iliac stent that we placed. So we literally did a little iliac kind of thing in the common iliac, extending into internal and external iliacs. And then we got very good flow. This patient's rest pain immediately disappeared. And then he's been doing great since. We have a 2-year follow-up on him. I think I have room for one more case, Kumar, correct?
Yes, go ahead.
So I will finalize with a third case, which is a different scenario. This is a 76-year-old female with renal transplant, you know, a lot of comorbidities, and cardiology patient. So they tried, and then they could not recanalize this patient, and they said this is impossible to cross, and they sent the patient to vascular surgery for a bypass. So to do a FAM bypass, when you have a common iliac occlusion, The surgeon has to clamp the artery. This kidney's creatinine is already on the rise, and by the time they referred the patient, it was 2.5 with a point of care creatinine, which was 7. And then at that time, surgery came to us. This is really not a good bypass if it can be intervened on. And they asked us if we could do anything. I said, we can always do something. So we had to set the case in their room, but we did the case. So if we were going to fail, they were going to do the bypass. So to be politically correct, that's how things were set up. So we came in. It was not an easy case, but we crossed very easily using an 014 crossing catheter. It was very calcific, so crossing that kind of getting a device over that was more difficult. And then we had to use kind of 014 balloons initially to predilate, etc. And let's see if my videos work. Right there, you're getting stuck in there with the devices. And but eventually, having the other access again helps. As you can see, we're doing our angiogram from the left side. The problem is on the right side. So keep your threshold low for getting bilateral access. If not for kind of establishing success, just to get your imaging better during treatment. And this is our guide wire in the aorta. You want to make sure your guide wire is free floating, not in the dissection plane. If you're in the dissection plane, then you may create a disaster. And it's also important to know where you're entering the aorta. When these occlusive diseases, and then you just kind of, you popped in, sometimes you'll end up in the aorta. If you end up in the aorta a couple centimeters, that becomes a problem. So I would actually, in my cases, retract my wire. Do not use an entry into the aorta above the iliac bifurcation. You can always kind of try another path, and then you come up and over, kind of meet those wires in the common iliac or external iliac, wherever it is, instead of being high up. High up can lead to a disaster and suboptimal result. So in this case, we are eventually kind of through. You can see our catheters in the aorta. We're injecting contrast, confirming it. And our entry, you can see, is right at the aortic bifurcation level. And so we have our stent position. We have our sheaths. One technique that's very helpful is if you use like 30 cm long sheaths, you get your sheath all the way up into the aorta, because if you're using balloon expandable stents, the surface of those stents are exposed. And then if you're crossing through a lesion, they may get stuck. You may have a hard time to get them, or even they may come off the balloon that they were mounted to. So if you use the sheath to get it up there and then unsheath the stent, you won't have that problem. And this is what we're doing here. As you can see, the sheath is all the way up into the aorta. Stent is there, and you pull your stent out. But when you pull your stent out, you also have to give the balloon enough room to deploy. If you put the stent and the sheath right next to each other, when you start inflating the balloon, which is longer than the stent, you may push things upward. The stent may kind of get stuck in the sheath and things may move upward. There's a little tiny thing that you need to pay attention. After doing that, you kind of go ahead and choose your location. As you see on this picture, the stent is being unsheathed and pulling back down long enough so you can adjust your stent and deploy. Since the lesion was so close to the aortic bifurcation, we elected to choose bilateral kissing stents, not to have that plaque moving to the other side problem. If you have about a centimeter of stump in the common iliac, you can avoid that. You can stent it unilaterally without having to stent both sides. But if you don't have that, you're going to compromise the other side. So this is our deployment. And the stents were deployed, and this is our final angiogram. This patient actually, after this is the rest. The kidney is getting very good blood flow. And this is the patient's creatinine count. As you can see, completely normalized. Now the kidney is saved, no issues without surgery. I'm going to conclude my presentation here. Thank you very much for your attention, everybody. Have a good Saturday.
Thank you so much, Dr. Arslan. Real quick for the trainees out there, any advice on when you're dealing with, you're talking about high rupture risk, what should they have in mind and be ready for if they're tackling these cases?
So if you're dealing with a kind of completely calcified and circumferentially calcified on CT, external iliac disease, that's when I would keep my attention the highest. You don't want to overdilate these unless that's your intention, but in that case, you have to have a covered stent ready to go and maybe pre-dilate with a smaller balloon like a 4, put your 5, 6, 7 Viabon, and then go ahead and crush it afterwards if you need better lumen. But even on those cases, you need to still be careful about the bifurcation points. If the rupture extends to external-internal bifurcation, that is kind of very difficult to come back from. So I wouldn't deliberately pay attention, be cautious, and when warranted, just be a little bit modest. You know, make sure you get a good result without putting the patient at risk.
Excellent, thank you.
I guess we're moving on to the next talk. I was trying to keep Rush out of this webinar as much as possible, but looks like we cannot. Dr. Solberg is not with us today, so we're going to have Kumar. Dr. Kumar Madasare decided that he's got a presentation and he can show us some complex FemPop stuff. So the next talk is going to be mainly about FemPop, but he's going to focus on calcified SFA, which is really the bane of interventions. It's the toughest disease to treat. You know, there are a lot of treatment options that were available in the past, which are not available because of all the, paclitaxel controversy. So this has been an interesting conversation, and this is something that we deal with in most of our practice, dealing with SFA intervention. So I'll hand it over to Dr. Madasare, who's Assistant Professor of Interventional Radiology and the Director of Advanced VIR Fellowship at Rush University. Take over, Kumar.
Thank you so much, Keith, and you look great this morning. You know, I wasn't planning on presenting today, but I hope we can get through this real quick, and feel free to interrupt at any time since this was not planned. We're talking about heavy calcified SFAs and why is that important, especially rock hard calcified occlusions of the SFA. And I think that's something that, especially as trainees get out there, you know, it's easy to cross an intraluminal 5-centimeter lesion, then you have all the tools and toys you want to finish with, whatever you think is right. But when you have these very long, very, very rock hard occlusions, the tough thing is, what do you do with these? And we don't have a great answer. But one of the reasons why you have a tough time in these is because a lot of occlusions have micro channels that you can sometimes get luminal and get through. But as they get rock hard, you lose those micro channels, which is why you're pretty much always going to be at least part of it subintimal in these occlusions. And that's okay for a lot. It's something you have to learn to be okay with not being luminal. We are all very comfortable not being luminal. We are subintimal in many of the cases that we take on, so that's something that we have to understand. Once you get somewhere with it, what do you do then? And you know, the question is, you've already said not going to bypass, so let's go with endovascular. You could spot stented areas that you feel that may help you instead of doing a full metal jacket. You can do what's called pave and crack, meaning you line the area with a covered stent, and then you put a self-expanding stent inside and really crack it open because you feel a little bit safer since you have the covered stent there. Aggressive balloon angioplasty, scoring balloon angioplasty, and also now we have lithoplasty, which is using the same theory as breaking up stones in the kidney. This is kind of a lithoplasty device. There's some data coming out. We're going to see how this pans out, but might be something that's going to help us in these type of situations. So here's a case example. I'm going to go through this, and we're learning as we go since I haven't done this in a while. But this is, although it's not SFA, it's aortic. You see how calcified these iliac arteries are, and you can see in the SFA here how rock hard these calcifications are. And this is just from part of the scout images. And you can see the runoff. There's no SFA there. Reconstitution of the distal SFA on the second image. And below the knee, you have a runoff with one vessel going to the foot. So initially, I treated the iliac to improve the renal transplant, which was struggling, which worked. Then the question is what to do about that SFA. You know that, number one here, you're not going to be luminal all the way. Pretty much I can guarantee that even if you come retrograde. You're going to be at least partly subintimal or mostly subintimal, and then you got to deal with those calcifications. I always advocate ultrasound access. However, as Dr. Arslan has taught me and Dr. Turba, if you see a calcified common femoral, you can sometimes just stick that under fluoro, but I advocate ultrasound all the time. You can see already the wire is taking a fun course. And as you come down here on the left image, you can see the path my 018 system is taking. It's not going in the lumen, it's spiraling in the subintimal space around the vessel. However, if you're lucky, you pop back into the normal vessel distally, and then you got to decide what to do. This is one of the earlier cases I did, and it's learning lessons. You can see that on that third image, I'm not getting much balloon expansion here, and that's reality, and that's something you have to learn. And you can see the balloon is very wavy on this picture. So early on, I put stents in there, self-expanding bare metal. I thought maybe this will be the key, and as you can see, it just doesn't get great expansion. However, I tried to crack it open with the balloon, and this is what I thought would be enough for him. He's going to do great. He did okay for a little while, however, as usual, came back very shortly, a few months later, and you can see it was occluded again. And that's probably because I couldn't get a maximal expansion of that even subintimal space. You can see on the magnet view right here, you can see how narrow it is just from almost extrinsic compression. Just to get through this was very difficult. I had to come from the foot, and you have to be ready for that, just to get across your occlusion that you already stented, snared it, flossed it out the body, so now you have from the groin to the foot, and then to really aggressively go after that ballooning again, and I put a balloon expandable stent followed by another self-expanding stent and really try to crack it open, and this is what the runoff looked like. You can see there's still a little bit of narrowing there, but definitely better. But in retrospect, I would have been more aggressive and maybe consider atherectomy, something else to really give me that channel, because that's what matters. You have a patient with wounds and you have these kind of calcifications. Some people ask, what about IVUS? IVUS will help you know if you're luminal or not, and what the plaque morphology is. But honestly, for a lot of these cases with calcified, you know what you're dealing with. It's just a matter of, are you getting enough expansion, which maybe IVUS will tell you, did your diameter get big enough? Because some stents, you want to make sure you have good expansion. Why plaque modification? Why do people believe in it? They say less significant dissections. You get lower pressure for balloon use. And sometimes it's just satisfying to have that. For the trainees, you know, no matter what you do, every time you balloon, you're going to get dissections, micro dissections or significant dissections. Whether or not you treat it, that's the question. But as you can see in the second image, you're going to get some level of dissection. So for a lot of these cases, I go antegrade just to get more support if I have running room. And you can see you can go ipsilateral, as you see in this cartoon. For me, in this little cartoon, I kind of go up and over, so all my sterile equipment drapes across the patient. You can reverse the sheath, which is something that I was taught very easily to do, and everybody can do, as you can see these videos. So if you're treating a patient, you know, and you're not staging them, it's nice to go up, see everything, and then come down. And then you can go on and you see these heavy calcifications, and you have to have a game plan here. So here's a case, heavy calcified SFA on a patient. In this one, I got the wire across, and you can see partly subintimal. I chose to do orbital atherectomy. Now, when you're dealing with any type of atherectomy in the SFA with chunky calcifications, be very cautious. You may deal with embolization. That's something that we don't want to take a claudican into a CLI patient. So be prepared, use distal protection if you're going to do it. Chunky calcifications are notorious for it, but after doing some orbital atherectomy and angiosculpting, which is a scoring balloon, really aggressively, felt pretty good about this response and put some spot stenting inside there as well. In this case, small lesion, looks very ominous, but you know, these calcified little lesions can be very painful. So aggressively ballooned it, and then decided DCB on this one. And now, of course, we're dealing with controversy, but in the right patient, you have to decide, is this for the best for the patient, or are you going to keep having them come back? And they may not be the best for surgery. Another patient here, complete occlusion of the SFA, and on the second image, you can see there's some reconstitution of the distal SFA pop. Tried to go down the same leg, had to go from the foot, was not able to cross. Eventually got through, snared it so that you get a flossing axis, as you see on the third image. And then you get aggressive balloon angioplasty, and then sometimes you don't have to stent at all. Here, you know, these are the cases where you do the angiogram, and as a fellow trainee resident, you're like, I got this. I'm going to kind of quickly try to get across before my attending comes in the room. That wasn't this case. I was the attending, but I looked at the fellow and I said, we got this. Let's get the next case ready. So you see the wire and catheter. I have a 4 French glide cath and a soft tip wire right here. I'm like, let's just see what happens. It's going to go right across. And you get really excited because this is a few centimeters. You're going to be done. You're going to do this. And then you see this. And this is when you know that things just got a little bit more interesting. You're subintimal. It's not as straightforward as you thought. This is the reality of what you do. You don't show it to anybody, but you get across, you pop back in. If you have to use a reentry device such as Outback or Pioneer, you do that. You can put targets, you can directly stick the pop and come back, but you get these results sometimes, and you have calcification. So having this kind of flap, you should not leave it magnified, multiple obliques or IVUS, whatever you want to do. You got to be really aggressive with it. In this case, decided to stent it. This should be the last case. You can see how hard it is once you cross a lesion in these calcified areas to pop open. This is putting a scoring balloon at about 25 to 30 atmospheres, but you have to do that if you're going to put stents or anything else. Otherwise, as I showed you in the first case, your results will be suboptimal, and that is not okay for the patient. His other leg, we also had disease. When I looked at it and decided in this case, I'll use laser. I know you love that picture. Again, when you're using SFA work, always use distal protection. As you see here, every time you ask industry or somebody in the case, they'll say, oh no, you don't need it. I see docs do it all the time. That's not a good idea. So here, I did laser, I aggressively balloon angioplastied, and then I decided to DCB at that time. And this is the result afterwards, which is great, but just remember, I was told I didn't need a filter, but this is what I got inside of it. So always be cautious, always trust your judgment, be safe, and be as aggressive as you can. So in summary, these rock hard calcified occlusions can be some of the most challenging cases. You have to be okay being subminimal, because in reality, we are most of the time in many of these cases. As long as you're lumen above and lumen below, you can decide your treatment in between. Aggressive ballooning and combining with atherectomy if you feel appropriate, and we'll see how it works with lithoplasty as more and more people are using it. We'll see if that helps us in these specific cases, but we'll see how it goes, and that's it. Keith.
Excellent, great talk, Kumar. That was very, so, you know, for the purpose of training, these are the challenging cases, and this is what we encounter a lot compared to the easy ones. Somehow they always end up with us. Kumar, so for a trainee who's starting off, okay, or even finishing fellowship and going to a program, what tools does he need to have for this FEMPOP interventions? Because, you know, sometimes you have one chance at this, right? You don't get two chances, you know, one chance. What tools would you say are basic necessities that are required? Just enumerate them if possible.
That's a great question. I think also a little caveat to that, you don't have one chance. For the trainee, it's important to realize that you own this patient if you're going to take it on. You are the primary caregiver for this patient. So you have multiple options, multiple chances. You have upfront conversations in clinic and say, we're going to take on this case of yours and I'm going to work with you, and we have multiple options. So I don't want trainees thinking that you only have one shot, because that's putting too much pressure on you. If you're going to take a patient on and you are that patient's doctor, you have to be smart and, you know, make the right choices and seek help when you need it. But tools wise, I think you need to have a few different balloon options. You have to be comfortable with retrograde access, because as Fadi and them have shown, there's different caps. So knowing how to do pedal access, having snares, having aggressive balloons, I think having scoring balloons, having at least 1 or 2 atherectomy tools, and having some stents. In these cases, it's easy that you might go extra luminal, extra vessel. So having covered stents, you should be comfortable with it. You have to be aware of how to use it. You know, in terms of specific tools beyond that, the basic tools that we use for PAD are the tools that you need. It's a question of, are you getting an optimal result from what you're doing, and what should that result be is what's going to matter. But don't ever pressure yourself saying, if I fail at this, we're done forever. No. Seek help, seek out all of us, seek out the people that you have as mentors before you take on a tough case, and know that it's okay to bring that patient back, as long as you bring that patient back and you own it.
Thanks, Kumar. Okay, so
that filter image was killer. That gave me goosebumps. That filter image.
I know, and it's funny, you know, I've done this as I was starting this practice of my own. Was I always ask the rep in the beginning, you know, what do you think about filter here? And they just want you to get to use the products, and they'll say, oh no, I see plenty of docs, they don't use filters at all. And that's the time you should 100% use a filter. Every single time your spidey sense kicks in, use a filter. Okay?
My rule about filters is, if you're thinking about if you should be using it, you should use it. If it's very straightforward, I mean, I don't use it regularly, I have to admit it. But if I see an angiogram that worries me, then I don't use it, I would get into trouble. So anytime you have it in mind, if that should be a case you should use a filter, just go ahead and use it and have a peace of mind.
Yeah, for the trainees out there, the worst thing that you can do is not that you failed that case. The worst thing you do is that you took a claudican into a CLI. And you should never do that. Many people do that, and we face the consequences of that for these patients. But don't be that person that does that. That's the pressure you should put on yourself. Thank you.
Excellent. Thanks, guys, again. Let's move on to the next topic. The next topic is access site complications. As you can see, Dr. Roshan Pant, who's actually the president of ISVR India right now. We are honored to have him with us. And access site complication is important because you may have an unsuccessful case, but you may have a complication, which is the worst thing that could happen, right? You may not be able to cross an occlusion and have a complication. You have created more problems for the patient than you would ever think about. So let's talk about how to deal with this access site complication. So Dr. Pant, please take over.
Thank you. This is a kind of different thing in the sense that these are like incision site problems in surgery. That's how I think about it. And it's what the patient sees and always remembers. I remember my father underwent a coronary angiography long back, and he was in bed for a couple of days and had a small hematoma on his groin. And then he underwent an angioplasty, which was transradial. And he was so pleased that he could get up, walk around, and he had no pain, no problems. So they always remember that. And remember, access site complications can be a major problem, can be life-threatening, get the patient to the ICU, and in the wrong patient can cause significant morbidity and mortality, right? So incidence is fortunately not high nowadays with the improved practice and the tools that we have. But even then, if you look at the global incidence or large series, you have, about 0.5 to 0.7% of the interventions require transfusions or surgical interventions. And in a significant number of elderly patients, they can lead to ICU and all the complications that entails, right? So this is something that we get to see once in a while, and I'm sure all of you recognize this as a evidence of a retroperitoneal hematoma with a compression of the bladder. I was called in for this case, and this was in a cardiac case, and this was the angiogram. As you can see, there's a bleed happening. Now, the conventional teaching is that if you have a high puncture, you get a retroperitoneal hematoma. This is not a high puncture. This bleed is happening rather low than high. So this is simple enough. So what we routinely do for such cases is to put in a wire from the contralateral side, put in a balloon, tamponade out the leak for 15 to 20 minutes, check a couple of times, and usually that works fine, as you can see in this angiogram. And that does the job for the patient. So I was surprised by this, so I did a little checking, and it's clear that at least half the patients who have retroperitoneal hematomas actually don't have high punctures. And this led to a lot of interest in this area for me. And a little bit of the data. Please look at this mortality for retroperitoneal hemorrhage. Now, in something like this, which is not seen by the patient as major surgery, where there's no major incision, number of sutures, staples, anything, you're not even under GA, this kind of mortality is just not acceptable. So we have to definitely try to avoid these kind of problems. Okay, so to understand why this happens, I'm sure everybody knows this. Basically, you compress the artery to stop the flow. In the meantime, the platelet plug forms, then fibrin clot forms, and then eventually tissue healing occurs over the next 30 days or so. And then artery is hopefully as good as new. Now, a lot of factors intervene in this normal course of events, and we know that these factors can be patient factors or procedural factors. And as you can see on the list, elderly patients, and to my mind, especially ones who have got abnormal renal function, are at high risk of having problems. All emergency procedures you got to watch out, and in IR we do a lot of those. Non-use of closure devices I have underlined because there are a lot of older articles. If you go across them, they say that the complication rates are the same whether you use closure device or don't use closure device. However, in the real world, if you look at registry data, the closure devices almost half the complication rate for at least the minor and major complications. So the way I see prevention is better than cure. So the prevention is very simple, and this is applies to all arteries, not just the femoral artery. And the right site, the right hole, and the right closure is very important. So the way I see it, you have to look at the location of the puncture, the size of the artery, and use the right tools for that. And if the artery has disease in that area, you got to avoid that puncture site. Okay. A right hole is the right kind of puncture, single hole puncture for thrombolytics or any major thrombolytic therapy. And the right closure, either use a closure device or do proper manual compression. Right. The ideal stick zone is known to all of you, so I won't go too much into that. But please realize that this is a small zone, and relying on the inguinal crease is completely doesn't work. So I tend to use ultrasound, particularly in this case. For example, this is a PVAR, an EVAR with the per close plug light. So always do this under ultrasound. So whenever I'm doing a large hole puncture, 8 French and above or 10 French and above up till 24 French, always under ultrasound. And especially in children also, I tend to use purely ultrasound guided punctures. And there is data from the FOSS trial, other trials, that there's a 50% reduction in complications just by using ultrasound guided punctures. Right. Closure devices, plenty of data, but there's a significant reduction in complications with closure devices, which majorly to per close and angioseal. They have their own problems. We'll see about that. Some volcanoes, unlike the one which I showed in the first slide, they are dormant. So they show up a little later and explode later. For example, this patient underwent a coronary carotid stent, and you can see that there. And we closed it with per close, and we were happy, sent him home. We had but that was in January, and in March, this patient developed these problems and had septic arthritis. And while he was under treatment in some other orthopedic center, he started getting this groin swelling with bleeding, and was transferred back to us. And as soon as he came in, sorry about that horrible photograph, but this was a poor mobile camera, and you can see there's a pseudoaneurysm there. And now this is a different beast, because you can see that arrow points to the per close probably in the arterial wall, and that's the cause of the problem. This is probably a mycotic aneurysm secondary to the arthritic bacterium getting into the nidus of the per close suture. We tried to temporize. We wanted the surgeon to operate. Surgeon says, I can't operate, hostile groin, post CABG, patient not in good shape. I don't want to operate. So we tried injecting thrombin. It seemed to work temporarily, at least. We put him in the ward, kept the surgeon in the loop. Antibiotic started, but 6 days later, suddenly, while the surgeon was not operating, he suddenly started bleeding in the ward. Luckily, the nurse jumped on it, compressed it, we shifted him to DSA, and here you can see the angiogram. As expected, there's a bleed there. So we slipped in a stent graft, not knowing what else to do at that point of time. Now, mycotic aneurysms, normally you don't put in a stent graft, but we felt we didn't have a choice, so we did that. This is a 2-year follow-up of the same patient. He stayed on oral antibiotics for almost 6 months. 2-year follow-up with Viaban, and it was good. So potentially, even in mycotic aneurysms, which are usually a strict no-no for endovascular procedures, you can place stent grafts, and there are some series, particularly in the aorta, which show that you can do this and you can get away with long-term antibiotics. Okay, so closure devices can have problems too, and you have to maintain careful asepsis at the access site. And the general principle is, in mycotic scenarios or infective scenarios, avoid endovascular. And if you have to go endovascular, then long-term antibiotics are the goal. Right. When you use a stent graft for an access site problem like this, you must remember that the stent grafts have to be self-expanding, which means they're at least 4 centimeters long. As you know, the target vessel where you're going to deploy it is a vessel which bends, and the common femoral artery is a no stent site. So my stent graft of choice used to be Viaban. We don't have that in India anymore. But the problem is, when the puncture is a little low, as the case may be, then you tend to jail the profunda. Not a good idea. So if you can avoid it, you try to avoid it. And if they can operate in this scenario, it's always better. So a different kind of case where similar thing. So looks like the first case we saw. So we said, okay, no problem. We go in, we put in a balloon, we inflated it, and unfortunately, despite prolonged inflation and larger sizes, it still kept bleeding. Right. So then we did something different. We went around the balloon, around the artery, and tried to find the site of extravasation and injected glue. After getting the right angle, injecting the right amount of glue, here we are, and the leak is closed. Now remember, this is all very commando operation like situation. You are in a cath lab, things are going wrong, patient's BP is crashing, he's got 10,000 of heparin and GP2, B3A inhibitors on board, and he's not clotting anything. So this kind of procedure is possible if you are used to glue and fluoroscopically guided procedures. Ultrasound is very difficult to use in this scenario generally, because somebody is trying to compress and you're doing things in between. The problem in these cases, particularly with cardiology, is high dose anticoagulation and drugs which prevent the platelet plug from forming and the fibrin plug from forming. And you must always be aware of the background potential coagulopathy and correct that if you're dealing with some access site problem. So percutaneous glue, I thought, when I did this case, I thought I had done something different and it was new, but when I checked the literature, it's been done before, as is usually the case when we look hard enough. And the interesting thing with this technique is that it works very well, and we get worried about glue getting into the artery, but really the artery is pushing blood out. So unless you puncture the artery and directly inject glue, the glue is not going to go in, it's going to stay out. Oblique views are very important to see exactly where it's bleeding from. Ultrasound can sometimes help, but I personally find it gets in the way of doing the procedure. Right. You can also use a coil. In this case, for example, a pushable coil. Now, this was a patient with poor INR, so his thrombin wasn't working for him. And we then decided to use a coil. What you see is the patent part of the aneurysm. Actually, it's a big hematoma. And we put in a microcatheter, put in one small coil because there was a narrow neck, and that worked fine. So that can be done in certain cases. You can use detachable coils now or pushable coils as you feel comfortable with. You can go transarterial through the neck of the aneurysm, or you can go directly puncturing the dome of the aneurysm and putting in a needle with maybe a balloon in the main artery to support the coils. But remember, this only works if you've got a narrow enough neck, as in neuroaneurysms, for example. If the neck is wide, like in the diagram below, then the coils will not work because they'll pop into the main artery. If you have a situation with a larger aneurysm, you can always put one coil at the neck and then use thrombin or glue, which usually works in that scenario and helps to block it off well. Sometimes the bleeding is not happening because you punctured the main artery. Sometimes, and I've seen this happen, particularly people who don't find the artery on the first puncture and keep trying various punctures. You can puncture the branches, this and that. In this scenario, if you can locate the branch, you can easily use a coil as in standard coiling for a bleeding artery and block it off. And a common complication is arteriovenous fistula. It's usually asymptomatic, but if symptomatic, I recommend surgery as the best option. Only if surgery is not possible, then a stent graft can be used on the arterial side to block off the fistula. Simple enough to do. Thromboembolism occurs from time to time, and there's a particular problem in pediatric cases. A lot of somehow I had exposure of this because of pediatric cardiac practice, which from time to time causes occlusion of the small femoral artery. And usually this happens because either a plaque dislodgement has occurred or there's a small dissection which is throwing emboli. This is like handling any other thromboembolism, and approach it similarly with the same guidelines. And I will not go too much into that here because that's a bigger talk for another time. A very unusual case here, which was shared by Dr. Sandeep Punamia, and this is, as you can see, a simple enough case. It looks like angiogram done and angioplasty done for the iliac artery. But 6 months later, the patient was back with bilateral claudication, and to our surprise, we found that he had developed severe intimal hyperplasia at both the puncture sites. This is very rare, but it can happen, and this is an access complication. Luckily, he was only a claudicant, so we conserved it, and over time, he developed collaterals and managed to be asymptomatic. In the current scenario, there are a lot of alternate accesses we use, and almost any artery which can be seen on ultrasound or access to palpated is punctured. So I thought it would not be wrong to just talk a little bit about the other punctures. Now, complications in radial access are uncommon, but they do happen. The commonest one being an occlusion of the radial artery. And there are variety of techniques to prevent this. Most often this occlusion is asymptomatic, but the best thing is to prevent it by using patent occlusion technique, higher dose of heparin, good punctures, ultrasound guided. Fistulas can rarely form and usually are asymptomatic. We don't usually treat them. Pseudoaneurysms are very uncommon. Haven't come across them. Basically, these are the techniques for preventing occlusion in the radial artery axis. Patent hemostasis means you put in the TR band or the occlusive force, release that force just enough to prevent bleeding at 15 minutes time, and then try to get the flow going while keeping compression on. Okay? Basically, the occlusion occurs because of spasm and thrombosis and increased duration of the occlusion. So try to avoid all these, increase the flow by compressing the ulnar, and you won't get a radial artery occlusion. Distal access is popular and frequently required, and again, fluoroscopy guided or ultrasound guided, we do it all the time. And complications, touch wood, have not really happened, so I don't really have a complication to show you. But potentially, all these 3 arteries can be punctured, and there are problems with each. And this is from my side theoretical, because I've never seen that happen. But any bleeding from these arteries, especially because these patients tend to be on low molecular weight heparin or antiplatelets, can cause compartment syndrome. So do not puncture them high up beyond the heads of the gastrocnemius, because that is particularly prone to compartment syndrome if punctured over there. The peroneal I have punctured just once, PTDP quite frequently. The peroneal is a rare artery to puncture, but sometimes that's the only one you have. And that is a deep artery, difficult to compress. You may need to use a balloon tamponade, internal balloon tamponade, to block the puncture site in this case. So you have a toolbox for dealing with puncture site problems, which in acute hemorrhage cases includes balloon tamponade, as simply done, glue sometimes, or a stent graft. For pseudoaneurysms, the standard is thrombin, which is very, very commonly done and very simple. But sometimes thrombin doesn't work. You may need glue, especially for larger aneurysms, or a stent graft in a given case, even larger, though I don't like using stent grafts in this scenario. And if possible, surgery. If glue and thrombin don't work, you should refer the patient for surgery. Remember, in all cases, look for coagulopathy and correct it, because nothing will work if you don't correct the coagulopathy. To sum up, prevention is the best approach to avoid access site problems. There are many options, but you have to choose the right one depending on what tools you're comfortable with, what kind of experience you have. I hope you don't have too much experience of access site complications. Most of my experience has been with cardiology cases. And I hope you don't have to deal with this, but if you have to, then it's best you deal with it yourself and don't need to call a surgeon. With a little bit of care and a little bit of expertise and the tools that we have available now, most of the time you can manage these cases quite simply and cheaply. Thank you.
Yes. May I ask a question, Dr. Pant?
Yes, sure. Absolutely.
So that was great for you made access complication, which sounds boring, a very interesting topic. So thank you.
Yeah, it's boring till it gets really exciting.
Yeah. We had a couple cases like you described. I mean, we use that balloon technique, unfortunately, quite often, thanks to our cardiology colleagues. As well. It's also interesting that anytime you talk about excess complications, cardiologists kind of are the mainstay of the discussion. And so we use thrombin though with balloon occlusion, in certain cases, especially the pseudoaneurysm posterior, etc., not safe. Instead of going with ultrasound, we like to go put a balloon and stick percutaneously and inject thrombin. Now you mentioned thrombin as well, but then you showed a great case with glue. So what makes you decide between thrombin and glue? Is it thrombin failed already, or the size of the neck, etc.?
Yeah. So the case I showed you was not really a pseudoaneurysm. It was free-flowing bleed. It was not really a pseudoaneurysm. It was bleeding continuously unless you block the artery, it would continue bleeding. There was no collection as such, and there was a huge retroperitoneal hematoma, and the patient was crashing. In that scenario where you urgently need to stop the bleeding, I think glue is the best bet if you can place it correctly. Thrombin is my preferred treatment for chronic pseudoaneurysms, and it works perfectly well in 90% of cases. It's only in rare cases that thrombin doesn't work, especially if thrombin is combined with some kind of neck modification, like using saline to make a narrow neck, or using a coil to block the neck before you inject the thrombin. These combinations work beautifully even in large pseudoaneurysms where traditionally you say a chronic pseudoaneurysm, very large one, thrombin is not so good. But we find that with these techniques, you can 99% time, I would say, treat the pseudoaneurysm without calling the surgeon. So that's my point of view in that. The problem really occurs not with the chronic pseudoaneurysms, but with the acute hemorrhages, like what I showed you. And this is frequently a problem with high doses of anticoagulation and GP2B3A inhibitors, which particularly cause problems in these cases. And they were not really bad punctures. If you see both the ones I showed you, they were common femoral artery. One of them probably was a posterior needle stick. It went through a double wall puncture and ignored it, came out and did not, take care of it. But otherwise, it's usually because of that problem. And it's very difficult to treat that in a cardiac case because they don't want to reverse the heparin with the stent in place, especially in acute MI. When you just put in a stent and got all the integral in going on or F60 they don't want to change the drugs. So you have to deal with it expeditiously. It
Thank you
really
very
helps
much.
to have this.
Dr. Pant, can I quickly ask a question, please?
Sure, sure.
About the glue, which glue, NBCA glue do you use? Do you use Truefill or Histocryl? I know in US
Histoacryl. Truefill is too expensive for India. We use standard surgical Nectacryl. We mix it with Lipidol to see it. And generally with this kind of scenario, I prefer about 1:4, 1:5 Lipidol and glue.
Nice.
The important thing is to target the place where it's leaking closest to the artery wall. That's the key. I've done about 3 or 4 of these, and that is what I find works. Otherwise, you can keep injecting Lipidol and glue everywhere. It's not going to help. You have to catch the point at which it's leaking.
Okay. I've seen somebody use the Dermabond as well. Like they actually detach the inner and suck out the Dermabond and mix it with Lipidol.
Yeah, same stuff. NBCA. I've seen surgeons use industrial glue. It's the same stuff again. Yeah.
Thank you so much, Dr. Pant. I really appreciate that. That was great. Oh, is there another question? Okay.
Yeah.
Okay, thank you so much for that. So we're going to move on to the next talk. We're going to talk about complex infrapopliteal arterial interventions. For this talk, we have the infamous Dr. Srini Tumala from South Beach, Miami. He's living the high life out there at University of Miami. He's the director of the Vascular Disease and Limb Preservation Program. He's also a very big social media icon. He's arranging YouTube channels for education. He has no barriers for anybody to learn. He's all about teaching. He's really passionate about this, and we know him very well in this regard. So we're looking forward to hearing about some of the tough cases that he can teach us about. Thank you, Srini. Is your mic on, Srini?
Yep. Sorry. Can you hear me okay now?
Yep.
Can you guys hear me?
Yep, we can hear you.
Okay, good. Everything's clear. All right, you can see the screen, right?
Yes, we can.
Okay, great. So I want to thank Rakesh, Kumar, Keith, and everyone for inviting me to give this presentation. It's a big honor to be with my esteemed colleagues. And everybody that knows me knows that I'm very passionate about teaching our trainees about peripheral arterial disease and specifically different techniques and how to do things. And so today I'm going to go very quickly through as many slides as possible. The first few slides are of some information that I think you need to know before I show you some of the cases and some of the videos where I show you the different techniques for recanalization and dealing with really below-knee disease. So these are my disclosures, nothing pertinent for this talk. Obviously, if you're treating PAD and definitely CLI patients, this is going to be your typical clinic, either on a daily or weekly basis. And you're going to be treating some type of patients that look like this pretty routinely. And everybody always wants to get some level of a 3-vessel recanalization, which is not always possible. But to do that, you have to have some understanding of basic tibial artery disease. When you're dealing with below-knee disease, you have to realize that you have really long diffuse stenoses or long chronic total occlusions. They're typically heavily calcified about 75% of the time, and that's even higher in diabetics and patients with CKD. And we know there's some early histologic work where they're finding cells of cartilage and bone in these CTOs below the knee. And so you can imagine that crossing these CTOs can be difficult and sometimes not possible. And, compared to above knee disease, SFA and popliteal and so forth, you don't have as many bailout options when you end up with complications such as long segment dissections and ruptures. Obviously, we've got a lot of these long drug-eluting stent trials that are taking place now. And what will happen is that adds something to the landscape. If you've never seen a CTO, well, this is what it looks like under a microscope. You can see that all these black arrows are pointing to really tiny, tiny micro channels. And so this gives you an appreciation for when people talk about guide wire escalation, 014, 018, 035, etc. And what they're talking about is trying to get these guide wires into these. Obviously, the more heavily calcified the artery, the more disrupted and the lack of microchannels you'll have, as Kumar alluded to. When you think of CTOs and below-knee disease, you want to really study your angiograms. You want to look at the cap morphology. Obviously, with CTOs, you've got a proximal and distal cap. And so when you look at these, although you don't have to, necessarily know the names in these guides, this is a nice paper written by Mustafa and Fadi et al., which really looked at about 3,000 patients, and they talked about different cap morphologies. So if you look at type 1 there, obviously that cap is favorable from an approach from above because your guide wire or catheter system are more likely to engage kind of the apex of that cap, and you'll at least start out intraluminal. Where you end up obviously depends on your recanalization. If you look at types 3 and 4, the idea is that your catheter or guide wire are more likely to hit that cone or the apex there and then slide off into a subintimal space. And so then you're going to have to do something to re-enter into the true lumen at some point, whether that's different guide wires, catheters, re-entry devices, and so forth, depending on where it is. So the idea is that just think about cap morphology. And here's an example of that. This is a CLI patient. You can see has a popliteal artery occlusion at the level of a knee joint. You can see that that proximal cap is pretty complex with a lot of big blood vessels coming off of it. Compared to the distal cap, which is really the anterior tibial artery, you can see that's a more favorable cap for a retrograde approach. So in this case, although I have antegrade access with my sheath and catheter system as distal as possible to obtain this angiogram, I decided to on a retrograde approach. And you can see that with a classic technique, it literally took 5 seconds. So it shows you that analyzing your angiogram, looking at the proximal and distal caps, very important and can sometimes make things easier in the long run. Another basic concept you want to realize is that when you're talking about CTOs, there's the concept of the hibernating lumen and the non-hibernating lumen. And obviously we talked about proximal and distal caps. When you have nothing in between, that is a hibernating lumen. That channel is patent. It may be angiographically occult, you don't see it, but it's patent and it's open. And obviously that type of recanalization, once you get through that cap, is much easier than say a CTO that has no hibernating lumen. In those cases, you can see that you're going to be fighting your way through that entire occlusion. And I'll show you why this is pertinent later. And here's an example of that. So here's a patient, again, CLI, has a large wound on the bottom of his foot. You can see the posterior tibial artery is out. We don't know the status of the common plantar artery, the medial lateral plantar arteries, and so forth. Once the recanalization was complete, you can see that angiography shows really robust filling of a lot of vessels there, and you have a nice angiographic wound blush. So this is a classic example of angiographically occult vessels that are really patent in between the CTO caps, and shows you this the concept of a hibernating vessel. Here's another case. CLI patient has a robust perineal artery with nice anterior and posterior communicating branches. You see there's a stump of a dorsalis pedis. So we don't know, do we have to recanalize the AT plus the DP plus the pedal loop? But once the recanalization was done, where we were through, our catheter tip is at the red arrow, you can see there's robust filling of a lot of blood vessels in the foot. These were all hibernating. They were open. They were angiographically occult. The final concept before we get into our cases is you really want to think about direct versus indirect revascularization. So when I look at angiograms, especially below the knee or below the ankle, in the case of pedal loop reconstructions and so forth, I'm looking to see that will I be able to achieve a direct revascularization, in other words, opening up the blood vessels that supply the problem or the abnormality directly. It's the main blood vessel to that target issue. Or do I have to open up blood vessels that supply collaterals, which then perfuse or supply the area of interest? And here's a quick example of that. This is an example of a direct revascularization. You can see patient has profound ischemia. You can see that the dorsalis pedis is out, the AT was out. We did a recanalization. In this case, I opened up the target vessel for the abnormality at hand. And after reconstruction, you can see that there's robust filling and then resolution. So that's direct revascularization, or angiosome directed is the other term you want to think about. When you're thinking about indirect, you can see here's another patient who had a TMA, has wound dehiscence, gangrene, and is obviously at risk for a major amputation at this point. I was unable to open up the anterior tibial or posterior tibial arteries, as this was a diabetic CKD patient. Didn't matter what I did. So what I ended up doing was opening up the perineal artery, TP trunk and perineal artery. And you can see that after that was revascularized, we have robust filling of really the anterior and posterior circulation of the foot. And in this case, we were able to achieve healing, although it took a longer time than a direct revascularization, with this indirect revascularization. So we open up a vessel, collaterals are supplying the area of the abnormality. So that's a quick concept. Now, the other thing you're going to be dealing with when you're looking at below knee disease, obviously, is crossing CTOs. And there are various names: penetration technique, drilling technique, knuckle wire, cart, etc. But the concepts are important. It's not the name per se, but when you're doing your reading or reviewing the literature or trying to learn about these things, this is what you're going to see in the literature. And I'm going to show you cases that really highlight some of this stuff. The first case I'm going to show you is going to be something that talks about the penetration technique. So with the penetration technique, what you're doing is you are rotating your guide wire slightly to one side, then the other side, and back and forth. So a little bit clockwise, then counterclockwise, or vice versa. And basically, you're putting a little forward pressure and trying to get through that CTO in that fashion. The drilling technique is just what it sounds like. You're rotating your guide wire 360 degrees while putting a little bit of forward pressure on the guide wire in order to pop through that initial cap and then get through the CTO. And to understand that, you obviously want to use guide wires with higher tip load. So what does that mean? If you've ever heard the tip load of a guide wire, what they're talking about is the minimum grams of pressure really needed to deflect or buckle the distal centimeter 2 millimeters. And what does that look like? You can see here, there's 3 videos I put together. So this on the left, far left, is low tip load, medium tip load in the middle, and high tip load on the far right. And what you can see is, you can see that the low tip load guide wire, it tends to bend or prolapse more easily. And as I get to the far right with the higher tip load guide wire, regardless of how much pressure I'm putting on it, it obviously does not want to bend or buckle or prolapse as easily. So that's the advantage of a high tip load guide wire. And this is why people talk about guide wire escalation in terms of tip loads and weighted wires and so forth. And that's for different talk, as you can imagine. So in this case, we have a CLI patient, has really a TP artery occlusion. My approach was to do this. I wanted to do an antegrade approach. And you can see now in the video, I have a catheter, I have a high tip load guide wire. I'm using the penetrating technique, basically rotating it back and forth to try to pop through that initial cap. And then once I get through, you can either use that technique or you can continue on. In this case, I was using more of a drilling technique. So I'm basically drilling through the CTO to achieve recanalization. Here's another patient. Obviously, CLI has a wound in the distribution of the anterior tibial artery, which was not healing despite optimal podiatry care. And after, workup with non-invasive testing and so forth, we took the patient to angiography. And my thought was, well, I have a pretty decent proximal cap, so I'm going to try antegrade first. I may need retrograde access, I may need dual access, but let me at least try from above and see how far I can get. And so my plan was to really recanalize this anterior tibial artery and then decide whether I have hibernating vessels in the foot or if I have to actually go after that pedal loop as well. And so now you can see in the video, if you look on the left, this is a classic drilling technique to get through the CTO. Hopefully you can see that guide wire. I'm basically rotating it in 360 degrees, and then eventually I get through multiple caps within the CTO, and then it basically sailed down on the distal 1/3. Why? Because that's hibernating lumen. It was open, and luckily I was intraluminal, and you can see the wire. Injection shows that we have robust filling of a lot of the vessels in the foot, and so a lot of those were hibernating, and then ultimately I was able to do good vessel prep, right? When you think of tibial vessels and chronically scarred down fibrosed vessels, you need some level of vessel prep, whether that's with scoring balloons, atherectomy, etc. So in this case, I did orbital atherectomy, I did prolonged angioplasty. How did I size my balloon? I sized it with IVUS. You can also use extravascular ultrasound to size your vessels, because obviously one of the things people tend to do is undersize tibial vessels. And so you want to really make sure that you are sizing appropriately and that you use good prolonged inflation, 2-3 minutes minimum, to really open up these blood vessels and really get an optimized result. So the next technique that you may read about is called the knuckle wire technique. And all that means is that you're basically using a relatively low tip load guide wire. You're creating a small loop or allowing it to prolapse, and then you're basically rotating it or pushing it through the occlusion. If you're lucky enough to stay intraluminal, then that's great. That makes your task much easier. On the other hand, oftentimes you'll be subintimal, like you see on the middle image there. And then you have to use either a catheter or other guide wires with different shapes, or maybe even a reentry device. They've talked about the Outback reentry device. You could use that as well, obviously in the proximal tibials, because it's very difficult to get it beyond there, to re-enter. Now, this is for if I have access from either above or below. And if you look at the image on the far right where it says it's showing you dual access, I have a wire and catheter system from above, I have a wire from below. They're in two different subintimal planes. I'm using the knuckle of the guide wire after it's prolapsed to really disrupt the tissue between those two catheter systems to achieve through and through access. So what does that look like? Again, here's that patient that we talked about, and now I'm going to show you the technique I use to revascularize this patient. Is that he's got profound ischemia, he's got gangrene involving multiple toes, and he's at risk for a major amputation here. And so I thought the best bet is let's go for direct revascularization and go after that anterior tibial artery. I thought my proximal cap was favorable, but I was thinking to myself, if I get stuck or can't make it all the way through into the foot, then I would go with retrograde access and go with dual access. So evaluation of the angiogram, evaluation of the collaterals, evaluation of the cap morphology, and whether you're going to do direct or indirect revascularization, very, very important in these types of patients. And so when you look now, you can see in the middle video that I have a catheter. I have a CTO catheter. In this case, it's a Cook CXI. You can use other catheters, Terumo, et cetera, et cetera. It doesn't excuse me, it doesn't matter. You basically want to use what you're comfortable with. And then I used a low tip load guide wire. I was able to create a loop, and you can see now I'm using a knuckle wire technique, pushing it through. And once I got partly through, then I'm using a different technique. I'm using a straight wire. I'm using a drilling or penetration technique, whatever it takes to get through. And I was ultimately able to revascularize this patient. Again, orbital atherectomy, whatever vessel prep you want to use, prolonged angioplasty, minimum 2 to 3 minutes. And then proper sizing of my balloons with IVUS or EVUS, extravascular ultrasound, which really allowed me to get healing in this case. Another case that's going to show another couple of techniques is obviously this is a CLI patient who's got chronic ischemic changes with hairless foot, shiny skin, thickened nails. He's got a large wound down to the tendons, almost the bone basically on his lateral foot. And after workup, took him to the angiography suite. You can see that we have basically occlusion of really all the tibial vessels. There's maybe faint reconstitution of a distal posterior tibial artery on that far right image. And so now I'm looking at the caps. I'm deciding to myself, do I need access just from above? Do I need dual access? Should I start retrograde first? How should I do this? And so those are all the things you want to think about when you're doing this. I'm thinking to myself that I'm going to probably need dual access to do this. And so in this case, I got my initial access from below. You can see there's a little knuckle wire technique on that far left video with a little loop. I pushed it up. In the middle image, I thought, okay, perfect, I'm done, case over. Then did the angiogram, and guess what? I'm basically subintimal. And so then I basically got a catheter system and wire from above. And you can see that my two systems are in two different subintimal planes. And so I have to figure out how to get them to meet. And there are multiple strategies you can use. So the first strategy to think about is cart, reverse cart, and double balloon technique. So what does that mean? So if you look at the cart technique, it just means you're putting a balloon from below. Typically, people like to use 2.5 to 3 millimeters when you're dealing with tibial vessels to really optimize that subintimal space and disrupt the tissue between the two systems, which then allows a guide wire to basically gain through and through access. Reverse cart just means a balloon from above, and then the double balloon means balloons from two different directions. And so you can see in this case, I basically did reverse cart. So I put a balloon from above, I did my angioplasty, and then that allowed me to recanalize from below and become intraluminal, eventually externalizing the guide wire, as you can see on the right side, and pull it out the sheath. I then reversed my access. So what does that mean? That means then I put a catheter from above over that guide wire, which is coming out the patient's foot, and advance it as distal as possible and distal to my access site. So when I do the angiogram, you can see the extravasation at the pedal access site. And that's not a problem because we're going to put a balloon across that to treat this occluded system. I eventually get guide wire access into the foot, into the loop, and then was able to deliver therapy. The other strategy that you can do, which I've started doing much more commonly because it seems to be work quite well, is that you're in two different subintimal planes, is what's called navibossing. So what does that mean? That means that if you look on the far left, my two systems are in two different subintimal planes. I use in this case a Terumo 4 French Navicross catheter, and I'm basically pushing it and rotating it at the site that I think I want to try to obtain through and through access. And I'm basically disrupting the tissue between the two catheter and guide wire systems. And ultimately, it allows me to get through and through access and I can externalize my wire. In this case, I had a sheath from below in the patient we're talking about. And you can see I did orbital atherectomy. I left my sheath open in order to let the debris clear out. Ultimately did prolonged angioplasty, minimum 2 to 3 minutes with good sizing via IVUS or EVIS. And then ultimately I was able to get a good 2-vessel runoff in this case. This patient luckily had some good hibernating vasculature in his foot. And so the pedal loop, although is not complete, is predominantly filling via his anterior circulation and a little bit via collaterals. And you can see there's a nice angiographic wound blush in his foot. It's when people talk about when do you stop, you think about number of vessels I've opened, you think about how fast the blood is flowing or flow rates, hemodynamic significance. You're thinking about angiographic wound blush, CLI endpoints. There's many articles on this and there's many things you can look at. And then over 8 months, we were able to achieve some level of healing. And on follow-up, I don't have his follow-up picture, but he did heal after that. Obviously, these are some now slides that were loaned to me by Kumar. This is a cart variation. So I have a balloon from below, and from above, they're using a reentry device, using the device to pop the balloon or at least gain access with the 014 wire, then use a micro snare, snare it, pull it out, and now you've got through and through access. So cart variation. Another one is the transcollateral technique, and you're going to see this as well. And all this is this is a form of indirect revascularization in this case. And what it means is that you're using collaterals to gain access to a CTO to either recanalize it, or in this case, as they did, to perform angioplasty and optimize your perfusion, in this case, to the foot. So one final case. I have two, but in the interest of time, maybe I'll just show this case. So here's another patient, CLI, has got a wound in the distribution of the anterior tibial artery. We obviously do our workup, non-invasive testing, and so on and so forth. I take the patient to angiography. I like to do my angiograms with antegrade access, either common femoral artery or proximal SFA access. Put my catheter sheath as distal as possible, in this case in the popliteal artery. That really fills a lot of the collaterals. It really shows you the arterial vasculature and the occlusions and the caps much more easily. And I thought to myself, well, that proximal cap has several collaterals coming off of it. It's the red arrow. So I thought this may be difficult to get through initially. So why don't I at least try retrograde first? I don't see anything there. When I did look with ultrasound, there was a nice pulsatile dorsalis pedis and distal anterior tibial artery. So then I knew that, you know what, I had some hibernating vessels here. I got retrograde access. You can see again, I have a low tip guide wire. In this case, you can use a V14, a V18, which is Boston Sci. You can use any host of wires, command 14, command 18, take your pick. I happen to use this one, got a nice loop. I pushed it, it went quite easily. And on the far right, you can see that the guide wire would not go any farther. Why? Because I was subintimal. So at this point, I decided to get access from above. And you can see now I have a 4 French Navy cross catheter. I have a V18 guide wire in this case. Again, just a low tip load wire, hydrophilic, and I'm basically pushing it. And where those two guide wires cross, that is a tip off, and you can do oblique imaging here to really visualize, to make sure that they're actually crossing, because where they're crossing is most likely where you have some level of access to get through and through access. So then in this case, I did Navi bossing. You can do all the other techniques we talked about, externalize the guide wire. You can see my technologist decided to put his finger on the extravasation site where we had pedal access, which is not recommended, but that's what he did. And then I was able to get my guide wire distal to our access site, do orbital atherectomy or some type of vessel prep, whether it's scoring balloons or basic angioplasty, etc. And I was able to really achieve a nice 3-vessel runoff by recanalizing this anterior tibial artery. And the final key is that you want to do good AP and lateral angiograms, as you can see here. And what I'm trying to look for is, one, do we have a nice angiographic wound blush? And you can see that we do, where the red arrows are. There was a nice angiographic wound blush. Patient went on to heal and did not need an amputation in this case. Do you want me to stop here, Kumar, or show this last case? It's up to you based on time.
If you want to fly through real quick, I mean, I think these are all amazing cases.
Okay, all right, I'll show you this case too then. So here's the last case. This one is a classic limb salvage case that I typically see. This is a patient who has You can see profound ischemia, gangrene, has MRSA infection, has basically underlying osteomyelitis. And unfortunately, our podiatrist that I work with thought it was so bad, decided to do the TMA without sending the patient to me first to see if maybe we needed to do some level of revascularization. And you can see at 2 weeks, initially after the TMA, you can see it looks fine, right? It's early, it's literally post-operative. And then 2 weeks later, you can already see that there's wound dehiscence, there's gangrene, and there's basically breakdown of the wound. And now this patient who had a TMA operation is really at risk for losing, his leg. So we did our initial workup. I did non-invasive testing in these types of patients. I like to get TCOMs or TCPO2. That's a test where you can see what the oxygen level or oxygen tension is within the tissues of the foot in this case, because I wanted to see after my intervention, did I make a difference? Do I have an improvement of those values to decide that do I have a chance at helping this patient heal? So you can see I have antegrade access here. Again, I have a 6 French sheath from above. You can see there's an SFA occlusion. I analyzed the caps. I was able to cross this quite easily and get distally with my catheter and then look at the distal runoff. And what I want you to pay attention to are 2 things: the popliteal artery below the knee joint, or the P3 segment as they call it. And I want you to look at how sluggish the flow is to the foot despite my catheter being at the level of the knee joint beyond the SFA occlusion. That's taking a long, long time. There's very poor filling of the distal vasculature. There's no angiographic wound blush. So you can see that this patient, just fixing that SFA may make it, fixing that SFA and most likely that popliteal artery may make a huge difference. So SFA was fixed. We're obviously focusing on tibial disease, so we'll move on. And what I will tell you is that when I did the SFA and fixed it, we had nice brisk flow. And so my next task was, okay, let's fix the popliteal artery because it's quite narrow. There's obviously disease there. And we saw that on IVUS. And while we were waiting, the patient's blood pressure was a little bit too high. The nurse was concerned, so we stopped. We controlled the blood pressure. And during that 10-minute interval while the nurse was getting the blood pressure medication we were going to use, the patient started complaining of numbness and a little bit of pain in the foot, which was different from what he had. And so then what did we do? We did an angiogram. And this is what it looked like. So now all of a sudden, this changed really the landscape. And now we're dealing with a below knee intervention and have to bring all the skills that we've learned over time in our experience in what to do. Well, we know here that at this point, if we don't fix this, that this patient's really at risk for a major amputation. And we have not helped this patient at all. We know that the posterior tibial artery was really the dominant vessel to his foot at the time of the initial angiogram. And so I knew that regardless of what we do, we have to do something. And the thought process here is, what is the etiology? Do we have debris from the SFA recanalization? Did clot form while we were waiting? No, the ACT was 250, so he was well anticoagulated. Do we have a dissection from a guide wire or from our intervention? Or is it all the above? So then you have to think to yourself, how am I going to manage this patient? So I didn't know what was going on here. So I said, well, you know what? Let's give 2 milligrams of TPA. Let's make sure the ACT is 250, which it was. And then I have to basically get through. In retrospect, I have a feeling that our guide wire had probably lifted up a plaque or dissected while we were doing all our manipulations. And so this shows you the importance of it as a trainee or even an experienced physician, that you really want to pay attention to these distal guide wires while you're doing your intervention. And so in this case, classic technique, right? Penetration drilling technique, got through, got into the posterior tibial artery, as you can see in that video. Once we got through, I made sure that the distal arteries were okay, and you can see the posterior tibial artery is robust. There's no debris or embolization, so it made me feel better. So then I did an angiogram above to take a look and see what we're dealing with. And you can see now we have a dissection in the popliteal artery, or the P3 segment. We've got a spiral dissection that's beginning, just at or beyond the anterior tibial artery, extending across the perineal into the posterior tibial artery. So then I said, well, how are we going to manage this? Well, I don't want to stent the popliteal if I can help it. So I did prolonged angioplasty. Did DCB, we got a decent result, not perfect, but good enough. And then I repeated the angiogram for this part of it, did again, prolonged angioplasty, no difference. And then thought, well, we have to salvage this. So then decided on therapy. In this case, we know that drug-eluting stents below the knee have good data in the proximal 1/3. Patency rates are decent. And so I used a sirolimus covered drug-eluting stent and placed it just beyond the anterior tibial artery. I wasn't worried about the perineal artery at this point because we know that the posterior tibial was the dominant vessel. If he didn't heal, I could always come back and tackle that anterior tibial artery. And this was the final after placement of the DES and expansion. It was sized with IVUS. Again, proper sizing, very important. You can see now we have a nice angiographic result with robust, rapid filling, inline flow. And look at the difference now. On the left is the pre-angiogram with a catheter in the popliteal artery because we knew that popliteal was diseased. And look at, I've already cycled two or three times on the post-final angiogram compared to that one. And you can see that, again, there's a nice angiographic wound blush. There's good filling of all the distal vasculature. And you can see here it is right here in the final. So a nice CLI endpoint. You can see non-invasive testing. ABI went from 0.6 to 0.9. If you look at that right calf waveform, we now have augmentation from thigh to calf, meaning that the volume of blood is increased after the SFA recanalization. You can see that on the TCPO2s or TCOMs, if you look at the red on top, that's the pre, that should be 50 to 70 or higher. Those are all 19.49, and you can see post, we're in the 40s, and we were able to achieve healing in this case and prevent a major amputation. So again, in summary, set yourself up for success. Become an expert at these CTO crossing techniques. You want to really perform high quality angiograms, including AP and lateral views of the foot with catheters and sheaths as distal as possible. I highly recommend antegrade access as much as possible for these because it really gives you better pushability, it gives you shorter catheter systems and allows you to gain access to these occlusions more quickly. Assess the cap morphology, collaterals, and distal targets with really proper angiography, and determine, am I going to need access from above, below, dual, and figure out what your access sites when treatment paradigm will be, whether it's direct or indirect. Remember, perfusion is unpredictable. You know, think of the angiographosome as Dr. Runbeck likes to talk about. You know, you do an angiogram, maybe the vessel you thought you should be opening is not the one, maybe it's something else. Accurate sizing with proper angioplasty balloons that are sized with IVUS or EVUS. Slow long inflations to reduce the chance of dissections and optimize luminal gain. Know your limitations and always ask for help. I call all these guys for help whenever possible. I want to thank you. It's been an honor. I appreciate the invitation. Thanks so much.
Fantastic job, Srini. While we get the next talk ready, in 30 seconds, there was a question for you. Filter usage and infrapop atherectomy, infrapop tibial. Any thoughts you can tell us really quickly?
Yeah, you know, most people do not. I have never used a filter below the knee when I'm doing tibial work exclusively. Obviously, if I'm doing work above the knee joint, then placing a filter either in the P3 segment or maybe a TP trunk or AT or something, you could do it, but I don't recommend using filters when you're dealing with below knee disease only. I'd be interested to hear what the other panelists have to say about it.
Totally agree. I think it's a time to exercise caution when using atherectomy below the knee, especially in our CLI patients. We don't have much of a runoff. We're gonna, in the interest of time, we'd like to go to our next talk, if that's okay. We're very lucky to have Dr. Maria Antonella Rufino from Torino, Italy, who's gonna give us a wonderful talk on the complications that you run into when you're playing in the infrapopliteal tibial space, which is, it's not to be taken lightly because you're doing all these complex cases, and be really interesting to hear what Dr. Rufino can teach us about this.
Thank you so much. It's really a pleasure to be here today with you in this, enjoying this new interesting project together. Can you see my slide or not yet?
Yes.
Okay.
We can.
So it's only me that I don't see them. No. Okay. My disclosure. So complication of femoropopliteal tibiopopliteal intervention can still compromise the outcome of this intervention that can be really really safe and effective. We have clinical complications that are related mainly to the patient clinical condition and pre-procedural complication that we already discussed before in a very interesting presentation. And now I would like to focus mainly on intra-procedural complications. So these are mainly arterial dissection and thrombosis, distal embolization, and arterial rupture. But let me please also add patient discomfort and pain during the procedure that can really make the procedure different if the patient has got a good compliance to all the steps of the procedure instead of being moving all the time and don't I'm sorry, and feel comfortable during all the procedures. So the strategies to reduce the incidence of this intraprocedural complication are adequate cross-sectional as already discussed, and dedicated devices. And the strategies in case of complication are mainly endovascular management. It's always nicer to take care of the complication by ourselves, not calling the vascular surgeon if not needed, and mainly in some cases for distal embolization, mechanical thromboaspiration, and medical therapy when required. So I was just, I said before, I would like to include into the complication of femoropopliteal and tibiopedal intervention the patient discomfort and pain. It's really easy to feel the patient comfortable and accept all the views that we need to get through all the procedure, in particular when we have a distal access. And so what we do is mainly to perform a US-guided sciatic popliteal nerve block with a local anesthetic and a saline solution. What we do is very easy to, we ask the patient to be in prone position, and we try to reach the sciatic popliteal nerve that is located deep between the biceps femoral and the semimembranosus, semitendinosus muscles. And the injection is performed right beneath the aponeural sheath, and then the patient can really, also the patient that are feeling pain, and not only rest pain, but also even worse condition, they can fall asleep in really few minutes. Moving to conventional intraprocedural complication, I would like to show you this case of arterial dissection in a 68-year-old male active smoker with hypertension and dyslipidemia, that who in May 2016 had right lower limb critical limb ischemia, so rest pain. In June, duplex ultrasound showed us SFA stenosis and distal occlusion with one vessel as outflow, and no autologous saphenous was available for distal bypass. This was the angiography, so we were with a contralateral access because of because the SFA was really diseased since the beginning, so there was no room enough to have an antegrade approach. And you can see we have a really small superficial femoral artery, stenotic and distally occluded with recanalization of the intercolumn and patency of the peroneal artery feeding dorsalis pedis, and very few small vessels to the posterior part of the foot. So we perform conventional angioplasty, and everything would have been fine except for a residual flap at the 1 centimeter below the origin of the SFA. So we managed to, the first option is this, in this case is to perform a PTA, so a low pressure PTA, and that's what we did with a 5mm balloon for 5 minutes, but in the end the result was not that different. So in this case we decided to deploy a self-expandable bare metal stand, and followed by angioplasty again at low pressure, and this was the result at the end of the procedure. We've restored patency, we fixed completely the flap, and the patient had no complication in this study. In other cases, due to the location, the anatomy of the lesion, and the situation of the patient, we have the the procedure to fix the complication can be a little bit more cumbersome, and so we need to perform a more complicated procedure. This is a case of 84-year-old male, former smoker with hypertension and diabetes, that in February had right lower limb breast pain, and the duplex ultrasound, what we saw was a tibial pedal trunk stenosis, outflow to vessels. So this is the angiography. So as you can see, that the trunk was very small, and at least 2 thigh stenosis. What we did as a first attempt, we tried to, since the anterior tibial artery was not giving anything to the foot, we decided to perform an angioplasty with a 3.5 millimeter balloon of the tibioperoneal trunk. And unfortunately, after this angioplasty, we have a dissection and an almost occlusion of the trunk. This was what happened at the angiography control immediately after the PTA. So we still keep a guide wire into the posterior tibial artery, and we shift from a conventional 5 French sheath, the one we use usually for the crossover. In case we need to work on fem-pop or distal tibial vessel, we shift for 8 French, and we decided to perform a kissing balloon of the tibioperoneal trunk and the takeoff of both the artery. And this is the final control. We restore patency of both the vessels. Distal embolization can be even worse. This is another case of a 91-year-old male active smoker with hypertension diabetes that in January 2015 had a right lower limb rest pain, and at the duplex ultrasound we found a P1, P2 occlusion and an outflow of 2 vessels. This is the angiography before at the beginning of the procedure. As you can see, we have a filling defect into P1, and what was not nice to see is the irregular shape of the proximal part of the occlusion. So what we decided immediately, according to the fact that we have yes 2 vessels, but the peroneal artery was very small, so mainly 1 vessel to the foot, we decided first to after patting the occlusion, we decided to use a distal protection device, so in this case a spider filter, and perform a conventional angioplasty. But after this angioplasty, we have really a thrombus. We thought it was mainly a thrombus inside P1, so that now was really difficult to decide exactly what to do, because there are different options, so thromboaspiration or thrombolysis, or just fixing the lesion with this thrombus with a stent. Since we have this study, a filter, we decided to go for this last strategy, so to deploy a bare self-expandable stent. And that's what we did with a good result in terms of patency. But as you can see, the filling defect just moved forward, and we added into the distal part of the distal tip of the filter protection. So actually what we can do, we were very lucky in this case, what we can do, we just remove the filter, and we had a restored patency of the distal part, P3. There was no thrombus left, and also the vascularization to the foot was not compromised. Another case of distal embolization is a 70-year-old male active smoker with hypertension. In 2000, bilateral SFA stenting. In 2014, a right hip replacement. In 2016, left endarterectomy, the common femoral, left carotid endarterectomy. And in 2017, a right lower limb claudication, so Rutherford 1 category 3. At the duplex ultrasound in February, we found an SFA occlusion from the origin of the artery to the anterior canal, with an outflow of 3 vessels and no autologous saphenous vein available for a bypass. So this is the angiography with occlusion with no stump of the SFA, a distal recanalization of the canal anterior, and 3 vessels to the foot. the option for a surgical option in this case is mainly an above the knee bypass, no saphenous vein available, so in diagram. But after discussion with the vascular surgeons, we decided for going first for an endovascular approach. And what we started to do from a contralateral approach once again, and a 6 French catheter in this case, because probably would have been again the need for another stenting. We decided we started to get through the occlusion, and we did it with a conventional O35 guidewire first with a balloon to help us to advance during this occlusion that was not that soft. We get into the stent already in place. We try to get through this occlusion with a pigtail catheter with that we usually cut in the distal parts of the to have more support along the vessel. And after that, we reach into the popliteal, the distal femoral, superficial femoral artery. We exchange a guide wire for a 018 guide wire, perform a PTA balloon angioplasty with a 200 millimeter balloon. And the result at the end of this, after the angioplasty, was not so nice. So something for sure would have been needed for accomplish our result. So, but during the next angiography, the patient started to have some discomfort and actually strong pain. And what we can see, what we saw on the angiography was this filling defect at the level of the distal popliteal artery and tibioperoneal trunk. Actually, after you can see we had clearly a stump distally to the popliteal artery involving this was this huge filling defect, filling the distal popliteal, the takeoff of the anterior tibial artery and the tibioperoneal trunk. What to do now? Call the surgeon that we tried to convince at the beginning of the procedure that the endovascular approach would have been the best thing, or do it by ourselves. So that's what we want to do. And there we had many options. One of those is the catheter direct thrombolysis, but in the main concern is still the bleeding complications. So after all the heparin and long procedures so far, we decided to go for a mechanical thromboaspiration with an 8 French catheter, and with a dedicated guide wire with a distal tip particularly shaped to for fragmentation of the thrombus and easier removal. And as you can see, with this 8 French catheter for thromboaspiration, we could achieve the patency of the popliteal artery, but unfortunately there was still a thrombus involving the takeoff of both anterior tibial artery and the trunk. What to do? Through the 8 French, we continue the thromboaspiration with a 5 French and 3 French catheter, and we could remove this thrombus that you can see is still inside our introducer sheath. So it was needed in this case also to remove the sheath itself and to position one another to perform the angiography for control. So as you can see, we have a restored patency of the distal popliteal and takeoff of both the artery, but unfortunately just the flow to the foot was still very slow. What we did also in order to fix some residual thrombus that have been still present inside the SFA, we decided to deploy a self-expandable cover stent and cover most part of the SFA. The result was good in the end, but we still need to check distally, and distally the flow was still impaired. So to help in restore the patency of all the vessel to the foot, we perform also localized thrombolysis with RTPA and 10 micrograms of nitro. And so these are these are conditions that can happen also very distally in tibial pedal intervention, as in this case, we have the same kind of embolization. You can see this long filling defect into the dorsalis pedis with a stop of the flow at this level that we manage again with a thromboaspiration catheter 3 French with complete restore of the patency. And this is what we can we could take out from the artery. But also another of the most challenging situation during the revascularization, femoropopliteal or distal arterial rupture. So this one is a case of a 69-year-old male former smoker with hypertension in 2014 as an above-the-knee femoropopliteal bypass in saphenous vein. In February 2015, a right lower limb claudication less than 15 meters. In March, a duplex ultrasound show SFA MP1 occlusion and, of course, also bypass occlusion, and with a runoff of outflow of three vessels. This was the angiography at the beginning of the procedure. So this, we suppose, was the stump at the level of the anastomosis of the bypass. We can see nothing of the bypass, but with only this revascularization of popliteal arteries at P2 and the distal vascularization of two vessels. So what to do? In these cases, we didn't, in case like this, we don't mind if we can recanalize the bypass or the native artery. Everything is good. In this case, it happened that we get into the old bypass, and what we have is during the recanalization a rupture of the bypass, of the vein itself, that we and then we perform immediately an hemostasis with balloon inflation. The next step for sure was this is the hematoma and the rupture mainly, and we check the size of the bypass, the patent bypass above this hematoma, and we decided to deploy a self-expandable covered stent at this level. This was the control, and actually we didn't pay too much attention to this small bulges above the covered stent, and so we decided to just end the procedure at this level. But 2 days later, the patient was back, and we, with pain and a swallowing of the leg, and what we saw, the duplex ultrasound was a bypass rupture above the implanted covered stent. We brought the patient again to the OR, and we deploy another self-expandable covered stent just above the first one. And this is the control at the end of the procedure. So recanalizing the old bypass or occluded bypass in vein is always challenging, because the vein itself is not good enough to survive to our revascularization. So in this case, what we learn is to always deploy covered stent, a self-expandable covered stent, in order to have an endoluminal bypass that can give a protection of the saphenous vein already in place. Managing bypass complication is also something that happened during our practice. So this is one last case, an arterial rupture in a case of 75-year-old male active smoker with hypertension. In 2014, a right femoroperoneal bypass in saphenous vein. In 2019, he got a right lower limb rest pain. In March, a duplex ultrasound shows us a distal anastomotic stenosis and one vessel to the foot. So what to do? This was the angiography. You can see this is the bypass, and we have this distal stenosis with a poor flow to the foot. What we first did was to perform PTA with a small balloon, 2.5 actually, and we have this huge leakage of medium contrast. We decided to deploy something that actually is off level in this district, but there's nothing other available for that. So we use a balloon expandable coronary stent graft, and we deployed at the level of the Raptor. As you can see, probably our balloon expandable stent graft was undersized according to the final size of the bypass of the vein and the distal arteries. So what to do now? What we did is actually to perform pulse dilation of the proximal part of the coronary stent protruding into the vein, and we seal the leakage, and this is the control at the end of the procedure. So just to sum up, femoral-popliteal and tibial-pedal procedure are safe and effective, but the complication can compromise the outcome for the intervention. We have to pay also attention to the clinical condition and comorbidities of the patient to avoid the general risk complication, and also during the procedure itself to make the patient feel less pain and discomfort as we can do. And the US guidance during the access, as already shown, can help us to avoid the access peri-procedure complication, but the combination of all the available techniques and devices is mandatory to succeed and manage intraprocedural complication. Thank you.
Keith, your mic, you're muted. Dr. Pino, that was a fantastic talk. While Dr. Pereira gets ready, for the trainees, do you think there's any benefit of more aggressive anticoagulation in those cases, or switching to a different type of intraprocedural anticoagulation? I know some people talk about higher ACTs or switching to other options.
Yeah, I think that in order to avoid distal embolization, we have only to pay attention to how we deal during the revascularization itself. What we do for as a intraprocedural therapy, we always go for 5,000 units of heparin and ACT range to 75-300, and we continue with 1,000 of heparin hour during the procedure. And that's what we do as a standard. Of course, this can help us on the side of the obstruction of the distal thrombosis or acute thrombosis, but on the other side, it can really make the management of a rupture even worse, because you have a patient that is really bleeding a lot, and so you have to be ready with a balloon to stop the bleeding as soon as possible. So I think that it's always good to have adequate anticoagulation therapy during the procedure, but it can also jeopardize other complications that can arise during the procedure itself.
Thank you. Yeah, I think we see sometimes we're behind the 8 ball when we find out some patients are non-heparin responders, and we're kind of behind the game in a lot of these patients. So it'll be nice if there's a way to figure that out early. Thank you so much.
Thank you.
Keith, I think you're still muted. Okay, so we're going to go on to a very exciting talk coming up on kind of the cutting edge area of, now we've gone below the aorta, we've gone below the inguinal, we've gone below the pop. Now we're going below the ankle, and we're privileged to have Dr. Vandenberg from Switzerland, who's going to give us some education for our trainees on this kind of new era that we've entered now in the recent past. Thank you so much, Dr. Vandenberg.
Thank you so much, Rakesh, Keith, and Kumar for having me in this global PAD bootcamp. And what I would like to do, it's always difficult at the end of a 2-hour session to be the last one, and I will try to stick within the time. This is what I wanted to discuss with you: some of the relevant anatomy, then something on strategy, then I will show you some technical tips and tricks, and then I will show you one representative case to make clear how I implement all this into clinical practice. So we all know that for the below the ankle area, we need to deal with at least the 3 arteries that we also deal with in the below knee area. That's the posterior tibial artery with the calcaneal branches, the medial calcaneal branch that you can see here that is still perfusing something below. And then we have the medial and lateral plantar artery, as you can see here. And I can really recommend this article already from 10 years ago by Clemens, which is really a very good description of the anatomy of the forefoot and of the arteries of the lower leg. Also, the dorsalis pedis, of course, is very important. And if we go a little bit beyond that, we need to know also about the metatarsal arteries as are depicted here. And then we have, of course, the perineal artery that still is considered to contribute a little bit to the perfusion of the foot with the calcaneal branch of the perineal artery as indicated here. And geographically, this shows like this. This is another must-read article by Mario Manzi, Radiographics, also relatively dated, but still very up-to-date because the anatomy, of course, doesn't change. Here you can see the anatomy radiographically. Also here on the right-hand side, the contribution of the perineal artery, and then here the common plantar artery, the medial calcaneal branch, as already mentioned, the medial and the lateral plantar artery, the contribution of the posterior tibial artery. Then we have two connections at the level of forefoot with the between the two systems, the dorsalis pedis and the plantar arch, with the deep perforating artery in the first metatarsal space. And then we have also a deep pedal arch, which is more proximally located, that connects the superficial branch of the medial plantar artery to the tarsal artery. And these are arteries that you can use in recanalization procedures by going through these collaterals. So what is the strategy in general in below the ankle treatment? Balloon angioplasty only. Stenting is really contraindicated. Of course, the dorsalis pedis is very obvious because people like to wear shoes. And then the pedal plantar loop technique and retrograde access, together with an antegrade ipsilateral common femoral artery approach, can really increase the success rate of your revascularization and clinical outcome. A little bit as what already was told by Srini in the BTK presentation. This is from a paper from Mariano Palena. This is also how I do it. Use a step-by-step crossing strategy. Of course, you need to evaluate any pre-op imaging or your diagnostic angiography, evaluating the proximal cap, distal cap, etc. But I always start with an antegrade approach endoluminally. I try, then I go subintimal, and if this is impossible, you don't cross at all, then you go for a retrograde approach. And this can be the pedal plantar loop technique, a transcollateral approach, or as a last option, the retrograde percutaneous puncture. It's very, very important to use optimal projection. Here you can see the connection between the dorsalis pedis and the lateral and the medial plantar artery, but it's not really clear where this connection is. And therefore you need very good imaging. Use distal angiography. Here you can see the hibernating vessels that were already mentioned. If you go very selectively, you see much, much more, and you see the connections better between the two systems. And also the crossing from the medial, from the dorsalis pedis to the plantar circulation. Use a projection that really shows you the connection. This tiny collateral that is now cannulated here on the right hand side is only clearly visible in this almost AP projection, and just orientate your C-arm in order to have an easy access and know where you are going. You can use the antegrade approach, and that is much more or less like the standard BTK. This is a patient with extensive disease. Proximally was treated proximally, but then having the distal angiogram, in this case, you can see that there is an improvement of the flow as compared to before. But since the lesion was at the first toe, we didn't achieve really the good perfusion of the forefoot that we needed in this location. And then you can do a BTA procedure, very distal BTA procedure, going with a wire almost up until the toenail, as you can see here, advance your 1.5 by 20 balloon that has only one marker inflated, as you can see here. And then this is the final angiographic outcome, and this is exactly where the patient had his problem. So go for the angiosome or for the angiographosome in this case. Then use the pedal plantar loop technique. You can use collaterals, wire and balloon tracking through the plantar arch, creating a loop from the dorsal to the plantar circulation of the foot, from the dorsalis pedis to the lateral plantar artery, or vice versa. And as I already mentioned, use roadmap techniques and AP and lateral projections to demonstrate the anatomy, because this is really key to get a successful navigation through the pedal arch. Then there are two techniques: the true pedal loop from the dorsalis pedis to the lateral plantar artery, antegrade, retrograde, and then also through collaterals. When you don't succeed, you need to use retrograde distal axis, AP projection for a metatarsal puncture, a lateral projection for a lateral plantar puncture. Use vasodilation, nitroglycerin or verapamil at the intra-arterial endopuncture site, and you can use ultrasound or fluoroscopy for access. Then a crossing strategy is as in the BTK area, preferably with an 014, sometimes with an 018 guide wire. Use a sheathless approach or a 3 French pedal access set. Angioplasty, low profile balloons. There's only one balloon that has a long, very thin shaft that will pass over its entire length through a 3 French pedal access set. That's the advanced micro. And then for hemostasis, you can either use external compression or internal hemostasis if the location where you punctured is not really accessible to manual compression. Again, from a paper from Mario Manzi, all the exercises that you can use, and I will show you just some other images where you can puncture, antegrade or retrograde, always away from flexion points, and choose an area of the artery that is as healthy as possible. Here you can see the optimal C-arm positioning for the various punctures, the pedal access set that you're probably familiar with, and then the 21 gauge 4 centimeter echo tip needles and an 018 or an 014 nitinol guide wire. Then for the sheathless approach, I use support or microcatheters. In the beginning, years ago, I used also typical microcatheters that we use for embolization, but we now have a lot of support catheters that have been developed for coronary use that are very useful for direct access, but also for transcollateral approaches, and I have listed some of them here. US guidance, of course, is the best way to go. You can see the wire entering the artery. This is a very distal approach on the dorsalis pedis, and you can even recanalize part of the occlusion with the wire, as you can see on the right-hand panel. If you don't manage, or the location is such that you don't see the artery sonographically, you can use fluoroscopy guidance, as in this paper from Nakama. Always put your needle in line with the artery or the course of the calcifications. You can also see that here, this was actually a combined fluoroscopy and ultrasound guidance. Here you can see the artery is really very tiny, and the bevel is partially inside and outside the artery with some extravasation. But in the end, I managed to get the dilator of the 3 French access set in, and now we have access in order to get through this occlusion below the ankle, where I managed to get in just above the ankle with the antegrade approach. How do we implement this in daily practice? And I will show you a case of a 77-year-old woman, rest pain of the right foot, occlusion of the anterior and posterior tibial artery. And this is her diagnostic angiogram. Actually, everything okay until the trifurcation. And then you can see that we have lost the anterior tibial artery and the posterior tibial artery. In the distal segment, there is a large peroneal artery with some collateral flow to very tiny dorsalis pedis, and here you can see a relatively good posterior tibial artery. So I went for the posterior tibial artery first. Here you can see I managed with the knuckle wire technique to get through, but could not re-enter, and actually a perforation was created, as you can see here. Here you can see the dorsalis pedis, which is very, very tiny, filling through collaterals. So I thought to go for that one. Here you can see again with a looped wire technique and a balloon catheter, trying to get all the way down. I managed to get into the dorsalis pedis, and again here the importance of a distal injection, the hibernating vessels that you can see is already mentioned by Srini. PTA was performed, but unfortunately we did not get antegrade flow, so also failure with the anterior tibial artery, and therefore we did not have any good direct flow towards the foot, the plantar side of the foot, where the patient has most of the disturbances. So looking again back at the selective angiography or the angiography, I made a selective angiography of the peroneal artery because there was a large collateral going to the posterior tibial artery or the plantar artery, as you can see here. And here you can see this corkscrew appearance of the collateral in the proximal part, and then a large, relatively straight segment towards the lateral plantar artery. And this was now my target vessel. And here we need to go slowly. This is the only collateral that the patient more or less has. We need to make sure that we keep this safe. So we start very slowly. Started out with an Armada XT, which is a short balloon catheter with a very nice and very thin tip, together with a relatively soft guide wire, the Terumo Advantage 014, but that had some difficulty in getting across this corkscrew appearance, and therefore I changed for a neurointerventional guide wire that I have on the shelf, the Terumo GT Gold. But you can use, of course, any other neurointerventional or very navigational guide wire in order to get through this tortuosity. And here you can see that now I manage to get through. And here you can see the corkscrew again with the Armada XT balloon catheter. Confirmation that we have crossed now, and what you see, and this is very typical, once you get through the coiling of this artery, the entire thing straightens out. At this point, I was able to change again for a stiffer guide wire, the Terumo Advantage, in order to proceed distally. And now I managed to get the balloon catheter all the way down, as you can see here, and now straightening out the vessel entirely, and the guide wire going into the distal segment of the lateral plantar artery, as you can see here. Then the balloon catheter was advanced. Of course, we had to go back up again. I managed to get the wire turning back by using the loop and pulling out the loop, and then advancing the wire into the proximal part of the lateral plantar artery and all the way up to the occlusion proximally. But here you can see that the balloon catheter is not advancing anymore. Now I'm escalating towards a stiffer guide wire, the Command 014 from Abbott, but still not possible to advance. And here it's time now to make another escalation, or actually go down and use a more softer and more flexible catheter. And I here used a support catheter to go through this entire track, and you can see how easily this now tracks up until the occlusion. With the knuckle wire, I cross the occlusion, I'm through, get my support catheter also through, check that I'm intraluminal, as you can see here. And then I keep this in place and use this support catheter as a track, and now I was able to easily cross-integrate, get into the distal part of the lateral plantar artery, as you can see here. First I go back into the collateral, but then I straighten out. Then I take out the support catheter and perform my procedure in an antegrade fashion, as you can see here. And this is the final angiographic result. Patient became completely symptom-free with a good angiographic outcome, as you can see here. So to conclude this presentation, it's very important that you know your anatomy. I briefly touched upon this. There are a lot of variations, and I really recommend you to read the 2 papers that I mentioned. You should have a large choice of material available. Make yourself comfortable with some of the guide wires, 1 or 2 of the support catheters, and of course your balloon catheters. Go always from low risk to high risk approach. Escalate with your wires, with your devices. Sometimes go down in order to be able to cross with softer devices. And then also use your IR embolization skills. We are used to navigate through this kind of tortuous anatomy when we embolize in different areas to increase your technical success. And by using especially the transcollateral approach, I think you can manage a lot of the cases, and the distal access is rarely necessary, at least in my hands. Thank you very much. And before ending, I want to draw your attention to the meeting AMP Europe, a similar meeting to the meeting that has been taking place in Chicago over the last 9 years. We started last year in Lugano, Switzerland in October. And given the situation now with COVID that is relatively under control in Switzerland and in Italy, we are able to do this live again. So if you can get out of the United States, I really recommend to join us to learn more on CLI. Thank you very much.
Thank you so much, Dr. Vandenberg. That's probably the greatest collateral revasc I've seen in recent past. That's pretty wild. For the trainees, do you have a general anesthesia for your patients to get such still pictures like that for the trainees out there?
No, we don't do anything. The patients are just with local anesthesia in the groin, and typically they stay relatively still. We don't sedate at all. In my experience, people that are sedated, even with some diazepam orally, they tend to move more, and you lose contact with the patient. And well, you could see from the roadmaps that this patient was really lying still without. I try to keep the patient in a very comfortable position. So don't try to, or don't ask them to rotate the foot. Just let the foot like it is, and rotate your C arm.
I think, it's very different in Chicago. We need anesthesia for a PICC line half the time, so that's very impressive. Your patient population is good.
Hey, Kumar, I have a question. Can you hear me okay? Joss, fantastic talk. A question for you. In the diabetic and CKD patient, do you have any tips or tricks in terms of what type of catheter or guide wire systems you like to use? Because those are obviously, with their microcirculation, it's very difficult, as you know.
Yeah. Well, I have reduced actually my my catheters in the lab, and also the wires in the lab to a minimum. I used to use a lot of heavy tip weight guide wires, but also you showed several cases where you use the knuckle wire, and if you create a knuckle proximal of the occlusion by going into a collateral and then create a knuckle and then push forward, you don't go subintimal, you stay intraluminal, but with that you have a lot of pushability, and you have a very low risk of perforation. that's the way I do it now. So I don't have the heavy tip weight wires anymore. I use currently the Advantage 014 and the Command 014, and then I have some wires from Asahi, really to puncture proximal caps, and that's all I have. I really went down from 10 to 3-4 wires in my lab now.
That's great.
Yeah, our lab would be happy if I do that, so maybe I should do that.
Dr. Arslan, I think you had a question?
Yeah, I was gonna make a comment about the anesthesia. The rest of the world is not as spoiled as the US. You know, the more you give, the more they want. And most of these interventions are done without any sedation in most countries. And as you said, you know, for nephew change, we had to use general anesthesia in some of our patients. It's tragic.
Yeah, I had the same experience in India too. We don't have them we don't have them keeping still like that, even in India. You might think. But I can't keep them still. I don't know. They keep moving. So I put them on GA or spinal. Spinal they don't give because of the antiplatelets. So it's mostly GA. Yeah, I've tried the regional block techniques that Dr. Rafina talked about. That seems to work for a short while, but they get restless. It's not just the pain. They just get restless. They're very, very ill people.
Yeah.
Interesting.
Well,
very.
Of course, we also have our patients that move, and we have a relatively low threshold for the anesthesiology. They are very available, but we try to do as much with the patient without any sedation as we can. What I have noticed when I moved to Switzerland 15 years ago, I really went to set up also to see my patients before the procedure, something that I didn't do when I was still working in the Netherlands. And people that have seen you before, and that's really why we need to be clinicians as radiologists. If you see the patient before, you explain them exactly what you're going to do, what they're going to face. That already takes out a lot of the restlessness.
Great point.
I mean, if I may add one last thing, I mean, this is being for the trainees. This is really, really important. It's more important than almost, you know, how you do the procedures, etc. Having a great patient a doctor relationship is the most important thing to establish and to grow your practice, not only with your patients, but also with your referring physicians. You know, you need to talk to every physician after what you did, communicate with them, etc. That'll bring you more patients. And as patients see you as their doctor, there are still IR practices that they do this sort of procedures without ever seeing the patient's face. And patient has no clue about who did their procedure, even though you may have saved their lives. This is ridiculous. We're the only specialty in the world that practices in this fashion, which is, from legal perspective too, it's like it may have very serious complications. I've seen IRs doing a great benefit to the patient, and on the other side, some guy does really stupid thing, torture, but they see him as their doctor and they blame the IR for something that goes wrong. So you want to be able to practice, especially vascular practice, you need to be doctors. There's no other way. Otherwise, you may have a run for a few years with a good vascular surgeon that works with you, but once that's gone, you're gone.
Yeah, I fully agree, Arslan. And just a small anecdote from my practice. A diagnostic radiologist in our institution, when the patient had a severe allergic reaction in the CT scan, the only thing that she was able to say was call a doctor.
Yeah.
That's familiar. That's familiar. I think that happens everywhere.
Yeah, and we must really start seeing ourselves as doctors. And I think the panelists here, they're really convinced and true believers of that. But I think if you really want to set up your practice, the people in training, the fellows, that is really a key point.
Starts with training.
If they call us for a headache, I refer them to somebody, but I don't say I won't see your headache. I'll say, you have a headache, talk to me. You have a backache, talk to me. Whatever you have, talk to me. I'm a doctor like anybody else. I can refer patients too.
Yeah.
That's how it works for us.
Yeah.
Yeah, I think that's really important.
Great. Rakesh?
So I don't know how I can thank you all, but these talks are just pure fire, and they were just amazing. I mean, everywhere from aorta to the inframalleolar, and as much as you guys make it sound very simple, I am 100% sure, and I speak for all the trainees, this is not a simple work. So that's why we have these webinars. That's why we have these international faculty teaching us. So we are very, very grateful for everyone here, whoever was present, most importantly, the faculty giving us the talks and teaching us and taking time on a Saturday morning. So with that being said, we appreciate you being here. Our next webinar will be the continuation of today's topics, and also we'll be touching back on the clinical perspectives of patient care, how to manage the patient's pre-procedure, post-procedure follow-up will also be part of these next talks in future, and will be announced shortly on our social media platforms. Please be on the lookout for that. And I want to sincerely thank once again, all the faculty members for educating us about the extremely important topic. It is a worldwide pandemic, which actually is more, has higher numbers than many people know, and a lot of patients need our help. So definitely helpful and helping raise awareness about the PAD and CLAD practice. Lastly, I want to thank everyone of the attendees who are taking time out for your day to join us. And we will be looking forward for your association again in future. With that being said, thank you, Dr. Pereira and Dr. Matsari for moderating the session. And Dr. Pun, Dr. Vandenberg, Dr. Chamala, Dr. Rufino, and Dr. Ursula. And you guys are legendary. Thank you so much for being here.
Thank you, everybody. Have a great
You're
time.
welcome. Have a good day.
Great job.
Have a good day. Bye.
Thank you. Thank you. See you soon.